psychiatrist at the University of Saskatchewan in Canada.
Thank you, Dr. Earle. It's a great pleasure to be here and follow Dr. Earle, whom I first ran into in 1999. And his work has totally revolutionized my concept of dementia. And I'm going to give some more clinical examples of what he's just been talking about. In case you don't know where Saskatchewan is, it is north of Montana and North Dakota. I live in Saskatoon, which is around here. Saskatchewan isn't quite at the North Pole, but the northern part's getting pretty close. And this is the city. It's actually a very nice city, minus 40 centigrade with a wind chill. So there are two seasons, winter and non-winter. And that's City Hospital, where I do most of my work. We have a very active clinic in this area, and I'm very fortunate that the therapists that I work with, and social workers, a lot of nurses, have all adopted the clocks and the exit, and we do a lot of trail making and sort of thing. I also work at a place called Moose Jaw. This is one of the few pure geriatric hospitals in Canada. The only problem, they have no geriatrician, so I go down there about 7 days a month. Now that I'm retired, we run through a large number of cases there, and I have a nurse that does most of the testing and helps me out a lot. Moose Jaw is kind of a famous name in Saskatchewan or in Canada, and I once saw a guy with a t-shirt on that said, "Where in the hell is Moose Jaw?" on the front. And then he walked by and he said, "We're 6.5 feet from the moose's tail." Okay, as far as I'm concerned, and Dr. Earle is the expert in this field, to understand the frontal lobe executive system is absolutely essential if you're going to understand how the clinical manifestations of dementia. It's much more than memory loss, and it's all about damage to one or more of the components of the frontal striatal phalanx circuit involved in the front part of the brain. Reiterate this, that most forms of chronic dementia either start with or eventually develop frontal lobe executive dysfunction. Doesn't matter whether it's Alzheimer's, it ends up as a frontal lobe disease. And that's all there is to it. And all the behavioral and the functional losses are the result of frontal lobe system dysfunction. This just can't be overemphasized. Now, what do the frontal lobes do? Well, the dorsolateral frontal lobes are very important for executive function. This has been pointed out. The anterior cingulate is very important for motivation, and the inferior orbital area is important for disinhibition. And also, there's a term called metacognition. Patients with frontal lobe system dysfunction just don't get it. They have anosognosia, reduced insight. And this is common, because one of the big problems of treating dementia or diagnosing is that people think there's nothing wrong with them. They just don't see there's a problem. And it's also very important for gait and balance and falls, and this sort of thing is really important. And also, continence of urine is another big problem in this area. And this is just my own version of the circuit that Dr. Earle has been talking about. Now, with some new imaging techniques, we're actually starting to be able to see the white matter very well. We don't quite do this in Saskatoon. We do CT scan or MRIs, of course, in this one situation. This is somebody with periventricular white matter change see why it would be interrupting the circuits from one part of the brain to the other. We do a lot of CAT scanning. The problem with CAT scanning is that you see rarefaction of the periventricular area, and these are often under-read. But the radiologists are getting much more aware of this in our hospital. Now, I just want to very quickly mention all of the different types of vascular cognitive dysfunctions. Vascular, one of the things that gets me down, and I know Dr. Royal has alluded to it, vascular cognitive impairment with no dementia. Depends what you mean by dementia, and we'll show this in a minute. Now, this is something that came out in a Canadian journal recently, where it was mentioned that vascular disease, or vascular dementia, makes up 19% of cases of dementia. And and the diagnosis and treatment has lagged behind Alzheimer's. I certainly will agree with that, but I personally think that vascular disease of the brain probably accounts for 80 to 90% of cases of dementia. They're just not diagnosed. And this just is a PET scan of someone with vascular multi-infarct dementia. They've had an infarct here, they've had an infarct here. Now, atherosclerosis is very important. No one will doubt that. In fact, when they talk about vascular dementia, they're often talking about atherosclerotic dementia. But I really think that the arteriole has been grossly underestimated as a cause of a mechanism of producing dementia. In terms of vascular cognitive impairment, in the early cases, the mini-mental is well preserved, as Dr. Royal pointed out, but they have poor executive function. They also often look like they have a Parkinson's gait. Because they have big ventricles on scanning, they get called normal pressure hydrocephalus very frequently, and quite a few of them get shunted, although this is happening less and less because the shunting rarely works. And then, of course, they have evidence of vascular injury. And then the other point that's been made already is this damage is often silent. There's no history of a stroke. Often, there's no history of a stroke. The patient is very happy to hear, or the family's happy to hear, that you think they've got vascular disease of the brain rather than Alzheimer's, because they often don't have any history of a stroke. And I shouldn't say that you don't ever see stepwise progression, but it isn't very common. Those are the cases that are recognized. The ones that are not recognized are the ones that don't have the stepwise progression. So we like to think of the brain arterial tree. In fact, an arterial tree. Anyway, you've got like the trunk of a blood vessel. You've got this is atherosclerosis, and cholesterol is very important in that regard. But you've got all these branches which are not affected by cholesterol. They are affected by hypertension and other factors that cause endothelial dysfunction, and this is really arteriolosclerosis. And that's what causes the ischemia. And so arteriolar damage is often silent till the disease is advanced. The main cause is hypertension. The kidney and the brain, and we see a lot of these patients have kidney disease, are two of the main target organs because of arteriolosclerosis. This is just an arteriole. What happens with an arteriole is the endothelium, we don't get a buildup of cholesterol like you see in an artery, but you get overgrowth of collagen and smooth muscle. The lumen gets small, the resistance goes up, and you get ischemia. In fact, you don't have to have an infarct. I mean, it's a situation like someone can have a myocardial infarction and damage a bit of muscle, and that can happen in the brain, presumably with lacunar infarcts. But you also get chronic ischemia. You don't get head pain, though. You show up with this executive dysfunction situation. This is from work at Wake Forest University where they're showing that you get ischemia of the oligodendrocytes, and these are the cells that make myelin. And over here is an area of leukoariosis with decreased myelin formation, decreased oligodendrocytes, and this is a normal area of the same brain. And the other thing with the vessels is the smaller vessels, the arterioles, as we age, they get very tortuous, which increases resistance further and impedes blood flow. And then we have these penetrating vessels that go in, their end arteries or end arterioles that go in and damage the white matter and damage structures like the thalamus and the basal ganglia and interrupt the circuit that we were talking about before. This is an example of an infarct, small infarct, complete infarct. This is an incomplete infarct. And this is an area where the wall of the arteriole has become markedly thickened and the lumen decreased in size. Now, Dr. Royals talked about type 1 and type 2 dementia. As I say, I heard him talk about this in 1999, and it has totally revolutionized my thinking of this whole area, in fact, in an amazing way, and I hope that others will pick it up. Physicians have been very slow to pick this up, it seems. Now, this is one of our long-standing hypertensives that's had a SPECT scan, and the front part of the brain is not perceived well at all. This is an elderly 85-year-old lady who's been hypertensive for 20 or 30 years. This is a person with Alzheimer's disease, and they are showing the typical occipital lobe hypoperfusion, but they're also, and this is an advanced case, there's also hypoperfusion in the frontal lobes, because this person has a good deal of executive function, dysfunction. See, this is the example of the hypertensive. This is where the parietal lobes are still, the parietal area is well perfused. But here, in this Alzheimer's, the parietal area is poorly perfused as is the frontal lobe and also part of the temporal lobe. This is just a little scheme I drew. This is where in Alzheimer's disease the problem starts in the hippocampus, entorhinal cortex area. It moves to the parietal lobes, then eventually to the front part of the brain. And this either is the Alzheimer's process, or else it's more likely vascular disease. It's been shown in a nun study. And if you just have confined, and the disease confined to here, you have mild cognitive impairment, but as it here's a full-blown case of Alzheimer's disease, and possibly mixed vascular Alzheimer's. Now, this is one of the first cases that I recognized in this area. This is a 75-year-old male. He had had a heart attack 7 years ago. In fact, I personally think that most people that have had a heart attack or have chronic ischemia of the heart, angina, probably have some vascular disease of the brain. You go to a cardiac meeting, for instance, I was at one on peripheral vascular disease recently, and they mentioned that, well, anyone with peripheral vascular disease is at very high risk of having a heart attack or stroke, and that's because the large vessels are involved everywhere, even though they may be asymptomatic. Well, the same applies if you've got large vessel atherosclerosis, you've probably got small vessel arteriolar disease as well. And this man, he became very apathetic. He had a shuffling type gait. He had many falls. His Tenetti gait and balance score was kind of in the ballpark of a child just learning to walk. And he showed some response to Paxil, but he had very poor response to cinnamon. His mini-mental was 27 out of 30. His exit was 24 out of 50. So this was a man that was showing a lot of apathy and a very poor gait and balance. I followed this guy now for several years, and he hasn't deteriorated all that much mentally. This is his SPECT scan. This is the back of the brain, which is well perfused, but the front of the brain is very poorly perfused. It happens to be a SPECT scan of a 64-year-old woman with frontotemporal dementia of the neurodegenerative type. I'm just pointing this out. It's not a vascular problem in her case, but it's a frontal lobe problem. It's a frontal lobe problem in the man with the vascular problem, disease, and it's very similar to the frontal lobe problem in this lady with very progressive frontal neurodegenerative, showing how profound the frontal lobe malfunction can be in some of these vascular cases. Now, this is I'm saying the myth of the normal mini-mental. Now, this has been well described today, but the problem with the mini-mental, it doesn't measure much about executive function, nor does it tell much about working memory. However, I've had some patients that have trouble spelling world backwards, which is a test of working memory, and yet the rest of their mini-mental was normal. And so, if you see someone, if you run into a patient with cognitive or behavioral problems and a good mini-mental, you should check the frontal lobe system. A few years ago, before we got into these tests, like the exit and the likes, we would see these patients. They would come in, we'd find their mini-mental at 28, 29, and we would try to justify that by saying they were okay. And we tried to, and nowadays, that we consider that ludicrous. We would do these further tests, but it's just without checking out the frontal lobe system, I think it's really you're really losing out. So the frontal lobe system should be assessed when the mini-mental is maintained, especially if the patient is young. And I pick up several cases a year of frontotemporal dementia, which one type is Pick's disease, because the person was young and they were called Alzheimer's disease. And when in fact they had frontotemporal dementia, they had quite a good memory, but they had a lot of executive dysfunction. And when people, we're in geriatrics, I'm in geriatrics, and we see numerous patients, usually elderly people with a history of hypertension or cardiovascular disease, especially bypass surgery, and we find out that their mini-mental is good, but they have profound deficits of executive function. I just can't overemphasize how common this is. So these are the kind of tests that we do all the time: clock drawing, trail making, exit 25. This is a man I saw a few years ago. He was actually he was an obese man and got put on insulin, and he had a lot of trouble with hypoglycemia. But he had also had an anterior head injury many years before, but his mini-mental was quite good. This was his clock spot, and it kept to draw clock spontaneously. Now he was asked, this clock was drawn by a resident who did much better. And over here was the patient. Now this isn't perfect, but it's much better than his clock's one. This was the clock's one, this was the clock's two. Because his problem was mainly in the front, not the back part of the brain. This is the guy we just saw the other day. This was an attempt at drawing clocks 1. Clocks 2 was impaired, but this is much worse than this. Trail making. We find this a useful test. This is a test of scanning ability. It's like connecting the dots. This is just the test pattern. It goes up to 25, and a normal person, elderly person, should be able to do this in 40 seconds or less. This is Trail B, which is a very good test of working memory, I think. You have to go 1A, 2B, 3C, 4D. It's pretty easy to go there, but once you get up around J, it gets to be kind of difficult. And we have all kinds of people that do well on Trail A, but have a terrible time with Trail B or can't even do it at all. I think that's, again, it's a good test of working memory. Now, we have done a study where we compared the exit 25 with the cognitive competency test. And these are the exit scores. 0 to 10 is somebody that's got good executive function, and people that have high scores are in trouble. The cognitive competency test measures 8 different functions, including management of high exit often had a low CCT, and people with a good exit had a high CCT. So this is another measure of the usefulness of the exit in predicting function, and we use it as an adjunct in addressing competency. Now, there are many ways in which microvascular disease of the frontal executive system presents itself. It isn't just one thing like vascular, it's numerous syndromes. And one is to convert mild neurodegenerative brain disease with mild memory loss into a major dementing syndrome. And also, secondly, and I think this is just incredibly common, it can be the sole cause of a dementing dementing syndrome characterized by both poor executive control function and a working memory deficit, despite a normal mini-mental. It can be the cause of a depressive-like illness that responds erratically to antidepressants, a dysmobility syndrome associated with a very high fall risk, a Parkinsonian syndrome that can either worsen idiopathic Parkinson's or be a syndrome in its own right. And this is very common, where patients are called Parkinson's, treated with Sinemet, and often are made worse because they have vascular disease of the brain. Then, of course, if you have large ventricles, you often are called normal pressure hydrocephalus. And then there's the overactive bladder syndrome. And then we've had a few patients that we actually thought had frontotemporal dementia, the neurodegenerative type that turned out to have vascular disease of the probably localized to the inferior orbital area. And I think the type of syndrome you get depends where the damage predominates. And of course, lots of people have more than one of these syndromes. And that's what we're just saying. I mean, if you have, the ventricular enlargement, you get more of a, you look like you've got NPH. If you knock off the fibers of the, damage the white matter, you get another syndrome. If you hit the basal ganglia, you can get a Parkinson's type syndrome. So, just going over the relationship between microvascular disease and neurodegeneration, one possibility, and DeCoteau has been saying this for a while, that the neurodegeneration of AD is really caused by microvascular ischemia. Another possibility is the microvascular damage, particularly involving the frontal lobes, is additive to the damage produced by neurodegeneration. Some people feel, and this makes some sense, is that the microvascular disease also damages the hippocampus, and you can have memory loss because your hippocampus is damaged. And then another thing that I think is, and Dr. Royal alluded to this, I think this is much more common than we think. It's where somebody's had a stroke and they become demented and they're thought to have developed Alzheimer's disease. I think we've seen patients of late that we actually think that they had the stroke and they were actually called, when they were called Alzheimer's with a stroke, when in fact they had major white matter disease that was probably causing most of their cognitive difficulties. And this is a man I've known most of my life that just was an example of this. He was a teacher, poorly controlled high blood pressure, had a stroke, refused, and someone said he forgot how to start his car, when I think it was his executive dysfunction that was really causing this problem. The CT, marked periventricular white matter rarefaction, plus subcortical lacunar infarcts, mini-mental 24 out of 30, exit 22 out of 30, clocks on 9 out of 15, clocks 212 out of 15. Neurologic diagnosis, large vessel stroke superimposed on AD. More likely diagnosis, large vessel stroke superimposed on chronic microvascular disease, made worse by sudden aggressive treatment of hypertension. Because these vessels are resistance vessels, and you have to be careful blowing the pressure too much. This is just to mention again that some people think that Alzheimer's is really non-genetic. Alzheimer's is a vascular disease. There's been several major symposia talking about the cerebrovascular pathology in Alzheimer's and vascular factors in Alzheimer's. This is a nun study where small strokes will worsen Alzheimer's. This is the one talking about how hippocampal and cortical atrophy predict dementia and sub-cortical ischemic vascular disease. This is a man I think we just saw again recently. This was his clocks 1, which you'll learn more about this afternoon. He actually noticed that he drew the clock a bit small, but this was his attempt to draw a clock spontaneously. He wasn't satisfied with just trying to draw his clock over here. He had to fiddle around with this one as well and put these arrows in it. But this man is showing both difficulty with executive function and also with his coughing parietal ability. And he had a lot of small vessel disease, and he had also had a couple of fairly recent major strokes. Now, vascular depression, I don't see too much of this myself. I see mainly people with apathy. This is kind of taken from the work of Alexopoulos, but these people don't respond as well to conventional antidepressants or to psychotherapy. At least that was the opinion at that time. But maybe with this circulating data, we have to rethink that. This was a typical situation we get into. This was an 82-year-old woman with a 50-year history of recurrent depression. She seemed to worsen recently after being in a remission for 20 years. Her mini-mental 26 out of 30, her exit 22 out of 50. She couldn't, trail B was markedly prolonged. The usual changes that we see in these patients. And the big question is, she was hypertensive for years, partial response to Effexor. The question is, was the flare-up of her old chronic depression, or did she have new vascular depression? And we don't, I think the latter took place. This is a case I just saw recently as well, a typical problem. A man was 78, he had apparent Parkinson's, quadruple bypass 4 years early. Whenever I see a Parkinson's with a history of bypass, we immediately wonder if this isn't vascular. He certainly had microvascular disease. He was put on increasing doses of Cinemet, which gave him psychosis, and he just didn't feel well. He was taken off the Cinemet, and he did much better. Vascular Parkinson. And this is common. It's not a rare thing. It's common. This was another patient that we saw many years ago. We weren't into the vascular business in those days, but this was a prominent physician that had Parkinson's and got tried on amantadine and immediately became severely paranoid. And then he'd have off periods where it looked like he died. I kid you not. They had to check his pulse to make sure he was alive. And just had gone downhill. Now, what I haven't shown on this slide, this man had a lot of microvascular disease as well. But he did get some response to Cinemet and those drugs. So I'm not saying he had just vascular Parkinson's. It could have been there could be an element of idiopathic as well. This is an old scan, but the frontal lobes before ECT treatment were very poorly perfused, and after treatment they improved markedly. And I'm not sure if we weren't increasing dopamine in the frontal lobes of this person, but he had many good years and then he relapsed and we couldn't bring him out of it. So patients with neurodegenerative diseases such as Alzheimer's, Parkinson's, Lewy body, and even long-time chronic depression are not immune to the development of microvascular brain disease, which can modify their clinical picture. And also, gait and balance problems are very important. Executive function is independently associated with performances of gait and balance. And as we saw in that earlier case, his Panetti score was very low. This was a lady we saw quite a while ago before we got into the exit business, but we eventually did an exit on her and it was quite high. But this is an example of how patients can be mislabeled with vascular woman, she had several falls and had a lot of pain. A long history of hypertension, white matter changes on CT. She had broken bones on x-ray, but the radiologist said they looked old. He didn't say they were old, so the physician thought they were old. And this woman had no business complaining of pain. Now, back many years ago, when she was a student nurse, she had a nervous breakdown. So then she obviously was crazy now, and with her pain and x-rays showing old fractures. Put on Haldol. This was before the atypicals came out. Had severe executive dysfunction on the tests that we were doing at that time. Her mini-mental was very good. Now, what happened? We did a bone scan on this woman. This is the bladder, but every other spot there's a fracture. She had about 15 fractures. And this was all related to the fall she had because of her white matter disease. And this is a vertebrae of a 20-year-old, a vertebrae of an 80-year-old lady. You can see how easy it is for these people to fracture if they have a fall. What we're showing here is 95% of people, 80 to 89, have either osteopenia or osteoporosis. So falls, and often brought on by white matter disease, are very, very important. This was a man with big ventricles, had a lot of falls. His Tenetti was 19 out of 28. His mini-mental was quite good. The exit at this time was only 15 or to 50, but over the months he worsened. Exit went up to 19. His Tenetti dropped down, and he did get shunted with a bit of improvement, more than our usual cases. That was his show. There were big ventricles on his CAT scan. It's called the Marriott type of behavioral problems, where the inferior part of the frontal lobes are not being perfused at this particular cut, but up higher, the cingulate area is well perfused. So this is behaviors are because of poor perfusion here. This is a person with the apathy syndrome. The cingulate area is poorly perfused, but the orbital area, frontal orbital area, is better perfused. Another thing that we see with these patients with microvascular diseases, they just don't cope. And they have trouble with handling drugs. They have problems with non-specific anxiety. And it's probably due to loss of brain reserve. They also tend to get delirium very readily. In fact, this is a man that I've known also for a long time, 69-year-old man, had total hip replacement, and poorly controlled hypertension for several years. Mini-mental was good, but he had a terrible bout of delirium after a hip replacement, which is unusual for a 69-year-old with a mini-mental out of 29 out of 30. His exit, though, was 31 out of 50, and I'll show you his clocks 1. This was his clocks 1, exit 31 out of 50. Clocks 2 was better, it wasn't absolutely perfect. And this took place on July 19th, the testing, he thought it was July 10th. This was another interesting case. I was asked to see this patient because she was going to be evicted from a seniors complex because her apartment was such a mess and she was hoarding things, and her family history was that. She had a very good memory, but she was apathetic. And she had been diagnosed as an obsessive-compulsive disorder earlier. Mini-mental 29 out of 30, exit 25 out of 50, and a lot of microvascular disease. Now, the family brought in pictures of her apartment because he said, "You'll never believe what it's like." And this is what it was like. But this is somebody who had this hoarding problem with microvascular disease and poor executive function. Just very recently, I saw this patient, 82-year-old female, developed a myocardial infarction, was put into the University Hospital in Saskatoon, long history of poorly controlled hypertension, intermittent depression since 1997. During the course of the treatment, cardiologist who studied her. But no one even mentioned in any way any possibility of cognitive impairment. We saw her down at Moose Jaw, where she was from, in Providence Place, mini mental 28 out of 30, poor clocks 1, trail A slow, could not do trail B, and her exit was 20 out of 50. This was her clocks 1. Clocks 2 isn't too bad, except it's small. But we see this all the time. No mention whatsoever of any sort of dementia. This kind of problem is so incredibly common, it's ridiculous. Another thing, I go to a lot of meetings on cardiovascular disease, the American Society of Hypertension, and some others. There's always a great deal of discussion about atherosclerosis and its sequelae, including myocardial damage, large vessel stroke, peripheral vascular disease, occasional mention of multi-infarct dementia. Microvascular disease as a cause of dementia is essentially never mentioned. Despite their importance and abundance, arterioles are essentially a forgotten entity. So it shouldn't be any mystery that persons with hypertension develop small vessel disease of the brain. It's no mystery that develop hypertension, that hypertension leads to renal damage. Everyone knows that hypertension leads to renal damage because of small vessel disease. Unfortunately, I don't know if the word unfortunately is proper, but because these patients don't have much short-term memory loss and have a well-preserved mini-mental, they are overlooked cognitively. And unlike the kidney, we don't have a test like the serum creatinine. So instead, we have to be aware of the clinical manifestations of small vessel disease, which include apathy and/or depression, executive dysfunction, disinhibition, often in varying combinations, and that include gait and balance problems. Tests such as the Exit 25, trail making, clock drawing can be very helpful, but they are more cumbersome than a simple blood test. But they are not that cumbersome. They can be done very quickly. In my opinion, small vessel brain disease plays an extremely large role in the production of dementia, either as a separate entity or as part of Alzheimer's disease. Persons with small vessel disease often have atherosclerosis, which can lead to a vascular catastrophe, such as a stroke or MI. In other words, if you've got small vessel disease, you've also got large vessel disease. If you've got large vessel disease, you've got small vessel disease. The good news about small vessel disease of the brain is that we might be able to retard this, which could in turn delay the onset of most forms of dementia. We recognize this too late, and in fact, it's basically unrecognized by many large medical centers. So the traditional concept of multi-infarct dementia greatly underestimates the global impact of cardiovascular disease on cognition and behavior. The Hashinsky criteria for multi-infarct dementia are quite specific, but they're insensitive. And so microvascular ischemia of white matter that doesn't produce obvious strokes, like hemiplegia or something, is largely overlooked. So we talk about the iceberg phenomenon in regard to recognizing microvascular disease of the brain. Now, this is just arbitrary, but if this is all the people with microvascular disease above the line are the ones that are recognized. I just want to end up by mentioning another point. Ernesto Schifrin at McGill University has shown that ACE inhibitors and ARBs actually can produce some regression of the hypertrophy of arterioles. And that's another form of treatment. The other thing, there are several studies out on impact of hypertension treatment on the development of dementia. Some of them are positive, some of them are negative. There's one study that showed that you actually worsen dementia by controlling hypertension. Sounds kind of silly, but I think you have to depend on who you're talking about. What we do as doctors is we get aggressive at treating of ignore it when they're 45. Another thing that's just come out recently is lacunar infarcts. At least some of them may occur as a result of endothelial leakage rather than a blockade. And we have to be careful with drugs like warfarin and Coumadin in these patients because we might be hurting someone by causing hemorrhage. Now, cholinesterase inhibitors are used in vascular brain disease. This is one of our patients that these are not highly effective drugs, but this particular person did very well after being treated with RiverCenter. But there are people that feel one of the main reasons why cholinesterase inhibitors help the brain when they do is because they improve cerebral blood flow. This was a study from Sweden showing that. However, there's a lot of concern that our trends of lack of exercise and obesity and all these things that we're getting worried about now will probably affect the brain as well. People with abdominal obesity, we see these all the time. They have hyperglycemia, insulin resistance, and the likes, and they get into problems with microvascular disease. I just want to point out that hyperglycemia, which is part of this, causes many, many different ways of injuring the blood vessel. Angiotensin II can turn on the production of superoxide anion, and this is worsened by ischemia, which uses up nitric oxide or combines with the nitric oxide to produce peroxynitrite, which is very toxic to the blood vessels. And of course, inflammation is a very essential part of this whole thing. The brain is very susceptible to oxidative damage. And this is even our famous amyloid, showing, and there's some people in several areas that actually feel that amyloid comes into the brain as an antioxidant. And that is not every. There are many people who disagree with that, but there are groups that feel that amyloid is an antioxidant. This is an example of a gerbil's hippocampus that has been exercising. The red is nerve growth factor, which is like brain fertilizer, and this is the hippocampus of a non-exercising gerbil. This is work done in California by Kaufman. And so anyway, I guess what it says, Mildred, I'm going for a jog. I'm feeling a little stupid today. And the other thing is that when we first start exercising, we produce more free radical and reactive oxygen species. But over time, our bodies adapt where our antioxidant capacity improves. This is a study done in Saskatchewan where a person named Earle has taken a group of rats that are prone to get hypertensive. They're bred to be hypertensive. He's fed them a diet of broccoli sprouts and has prevented the development of hypertension in the offspring of these rats. And of course, there's the famous antioxidant diets. And of course, Robert Butler makes the statement that a pedometer is the most useful piece of exercise equipment an elderly can own. Of course, we may get into this situation, take 2 aspirin, these antibiotics, a statin, niacin, folate, estrogen, an antioxidant supplement, ramipril, and don't forget to relax. So anyway, we mentioned this before. Vascular abnormality is grossly underestimated in its regard in its role in producing dementia, but it's probably easier to prevent than neurodegenerative Alzheimer's disease by the practice of good health measures. And I hope this doesn't refer to me. Healthy body, some place of age. I'll stop there. Thank you.
Yeah, probably.
So it's used a lot in rehab settings, but the exit is something that your medical student can do at the bedside.
Yeah, we don't do the CCT that much. It's more, this is more of a research.
Yeah, it's more of a study.
See how it stacked up with the exit.
Yeah.
But we use it when we have these competency situations. It's another tool. It's another bit of information to give families or bodies that are, where you're having to declare someone competent or incompetent. I guess the point I want to make, this is a very far-reaching syndrome. And it isn't just, it isn't just a bit of mixed dementia or a few things like this whole business of Parkinson's, falls, incontinence of urine, normal pressure hydrocephalus, and they're all part of this syndrome.
Aaron Short from Tufts. I'm a biologist, so I'm learning more about the clinical setting here in this conference. From a clinical perspective, how useful would it be to screen broadly for perfusion deficits? It's my understanding that SPECT studies and PET studies aren't frequently used. I mean, would that be important given the claim here that type 2 dementia is really the most frequent kind and it may be related to small vessel disease, which otherwise can't be diagnosed?
Well, it'd be interesting. The problem that we have is our SPECT, our SPECT scanning is not very good. I mean, when we have a positive SPECT scan, that means there's an awful lot wrong. It's too insensitive in our hands. And I know this will be hard for many Americans to believe. It's being a very poor country. Canada can't afford a SPECT scan or a PET scan. We don't have any in Saskatoon. We don't have any in the province of Saskatchewan. So I don't know. It would be of interest to do that. But I think we're going to help vascular. Help the vascular situation of the brain. We have to recognize people earlier. But I think, I may be wrong about this, but I personally feel that somebody with coronary artery disease and with the risk factors for coronary artery disease also probably has the same risk factors for brain disease.
Essentially, though, that means that there's a somewhat circular argument in the sense that we're defining vascular. We can detect these microvascular dementia based either on the risk factors that people have or on the basis of neuropsychology, which reports to identify that. But other than that, how do you really get at people who have this microvascular disease?
Well, in a sense, it's a similar problem to Alzheimer's because we attribute Alzheimer's to neuropathology, but you can only look at that autopsy. But you can't image Alzheimer's. So clinicians aren't really that comfortable with making diagnoses referable to CNS pathology that they can't image or do a blood test. I mean, that happens all the time. As far as a study, though, I collaborate with the Honolulu Asia Aging Study, where they've studied a cohort of 8,000 Japanese Americans now for 30 years. And since 1991, they've been systematically collecting their brains in autopsy. So in that study, they had measures of, amyloid in both the neuritic form, plaque form, and the diffuse plaque form, Lewy bodies, lacunar and large cortical strokes, and neurofibrillary tangles. So if you add all those together, how much variance in cognition do they explain? The answer is less than 20%. Right? So then you add age on top of that. Age gets you another 5%. So now a quarter of the variance is explained by the combination of all of those measured, the actual counts of these regions of the brain. Then you add microvascular ischemic lesions big enough or small enough rather to be seen on a microscope, but unimageable, right? And you can add another 20%. And then there's no count in there for white matter, but state-of-the-art neuroimaging that I'm going to present some later in the VasCog Conference. White matter markers with modern instrumentation themselves explain about a quarter of the So, ironically, it may be that microvascular lesions that you can't image even on MRI and white matter change explain almost half the variance, the measurable variance in cognition, and that the Alzheimer's lesions are relatively small but independent predictors of some variance in cognition. And this goes into what I was saying earlier. When it comes to Alzheimer's lesions, it's specifically the tangles that predict cognition. Amyloid doesn't predict cognition independently of tangle counts. And again, even though Dr. DeCoteau showed some pretty standard slides about amyloid maybe being related to oxidative stress and things like that, oxidative stress, is a random process consistent with the distribution of amyloid, which itself does not predict cognition. Tangles are spreading hierarchically, retrogradely, and transsynaptically from particular portals of origin. That can't be described in terms of amyloid-mediated cell death or oxidative stress or ischemia. In other words, if you want to have a model of Alzheimer's that reports that the tangles are caused by ischemia from a microvascular lesion, then you have to explain why microvascular lesions or ischemia would spread retrogradely and transsynaptically from a particular origin in the brain. And frankly, the brain's vascular risks aren't distributed like that, either in space or in time. So I don't really think tangles are going to be fundamentally related to ischemic or vascular-related processes, although amyloid. Okay, well, I think that's a whole lot of information to cram into somebody's brain before lunch. So why don't we let you all go for lunch, and we'll pick this back up in about 1:30, I think is the program. I'm sorry? 1. Okay.
1:30.
I heard it's sprinkled. Let's say 1:30.
Yes.
Okay. And if the weather's good, be sure and try to get down on the river walk. Because you'll enjoy the walk and the food. Recommendations.
The blue and red to break down the patients with diabetes. Could you just comment on what proportion of those patients also had or didn't have significant hypertension and or cerebrovascular disease that would kind of serve as a confounder in really establishing what exactly the role of diabetes is in terms of the risk factor for dementia?
Right. Okay, so the diabetic study, we never published that. It's just like one of my fellows projects. And we did it years and years ago. I mean, I can't remember why the fellow moved on or something, and I only recently rediscovered that data set. But basically, the way it was they just went down to diabetes clinic and screened everybody who came in. Okay, so automatically, if you think about this, how much executive function does it take to make it to diabetes clinic? Really executively impaired people don't make it to clinic effectively. They're your no-shows, right? They're at home. They can't even get the act together. So there's already a selection bias. On average, let's see if I remember this right, 48% failed the exit, 75% of those had a normal median. So if they had comorbid vascular disease, it wouldn't have been sufficient to affect their median scores. I guess what I'm saying is we don't have imaging, so I can't really answer your question directly. In a multivariate model, the exit was the strongest predictor of functional status in these diabetics. It was stronger than age. It was stronger than the number of organ systems affected by diabetes. We did screen them for every organ system that was affected, and one of those would be stroke, so that would be one of the items on that. It was stronger than hemoglobin A1C. It was stronger than red fasting glucoses. It was stronger than depression screening measures. It was stronger than the minimal. And the strongest predictors of executive impairment were taking insulin as opposed to oral agents, achieving tight control, and hypoglycemic symptoms. So the strongest predictors were not, the mini-mental and the number of organ systems affected by diabetic sequelae. It was actually taking insulin, achieving tight control, and hypoglycemic symptoms that predicted the exit score. And there's a literature actually of functional neuroimaging after hypoglycemia in experimental hypoglycemia in diabetics. And so it's not correlated with the current blood glucose. And so giving them a sandwich or a candy bar or orange juice isn't going to make much of a difference, because it takes hours for the frontal lobes to come back online after this insult. You know, the brain uses more than its weight of glucose, and the frontal lobe uses more than any other brain region's glucose. It's one of the most metabolically active regions in the brain. So the frontal lobes are very vulnerable to hypoglycemia, and I think that diabetologists grossly underestimate both the prevalence of executive impairment, its contribution to diabetics' functional status, and the risk of achieving tight control. Because the rationale for achieving tight control is that it prevents retinopathy, but vision does not intermodel with function status independently of executive function. So blind people go to college, executively impaired people are homeless. So I think that basically a more enlightened view of what the treatment goals of achieving tight control are, you might actually find that executive impairment is a stronger predictor of time to amputation in a diabetic than fasting glucose for hemoglobin A1C. It's just that nobody has thought to do design experiments like that, because the neuropsychiatry literature is too trapped in an irrelevant model of dementia that doesn't inform what's happening in diabetics.
Can I just follow up that? There was a study that came out recently, I can't remember the exact citation, but it was commenting on the cognitive course in patients with diabetes, looking at relative episodes of hypoglycemia versus hyper. If I remember correct, actually patients who had hypoglycemic episodes in general, in the long run, did better, but maybe they weren't specifically isolating out, for example, from executive functions and the impact on it.
Well, I think I saw that picture because I kind of monitored the diabetes literature with this stuff. And, you know, it's basically that people design batteries that are insensitive to